by thanking Dr. Kastner and Dr. Chambers for inviting me to give what I think is a very interesting talk about a very interesting subject. What to do about the asymptomatic ADA2 patient, and perhaps I'd like to add to that title, does that actually exist? My name is Taryn Youngstein. I'm an adult rheumatologist at Imperial College Healthcare Trust London. I work clinically at the Hammersmith Hospital, and I also work at Imperial College London in the National Heart and Lung Institute. These are my disclosures, none related to the work currently being presented. So the plan, what do we need to know? What do we know, and how can we get there? So what do we know? Well, we do know that asymptomatic biallelic variants in the ADA2 gene have been reported with low or absent ADA2 activity. But when you critically review the literature, most of this refers to a single published family. And that family I know very well. They are a family of Pakistani origin with one sibling initially very significantly affected. This family has been reported in a very highly cited paper on ADA2 by Taryn from Thailand, who at the time was working with Professor Brogan's team at Great Ormond Street. And then the family transitioned to under the care of Professor Helen Lackman at the National Amyloidosis Centre, London. So it is with thanks to both these teams that I present these cases today. The index case initially presented aged 1 year with an intermittent livedoid rash, recurrent fever and ischemia of his little finger. He then sustained a stroke at age 3 years old with fever and had a low acute phase response at that time. He was transferred to Great Ormond Street in London, and a biopsy of a vasculitic rash noted on his feet revealed necrotizing vasculitis with polymorphs, and a diagnosis of polyarteritis nodosa was made. He was treated for 5 years with azathioprine and infliximab, and he was in remission. And this was prior to the initial descriptions of ADA2 coming out in the New England Journal of Medicine, both papers of which will be no strangers to this audience. And what was found when eventually the family was genotyped was that they had a Pro251 Lu mutation that had been reported in one of the initial reports. This was a loss of function mutation, and in silico modelling predicted that it would introduce flexibility and a large hydrophobic group, leading to destabilisation of the hairpin turn and disruption of the enzyme active site. This I have modified based on the knowledge of the family when I have met them, and adapted it from the original publication. In essence, the parents were second cousins and the maternal grandparents were first cousins. So all children were homozygote for the mutation, and the father was a heterozygote and the mother had 2 copies of the abnormal gene. A number of other family members were also genotyped, but none had any symptoms. So I'll tell you about the parents. The mother at the time that I met her was 41 years old. She was a housewife and had a lifelong livedoid rash. It was faint. She had a significant history of migraine and right-hand paresthesia, which on clinical examination was consistent with carpal tunnel syndrome in her dominant hand, very common finding. She had a history of intermittent fever in the past and significant hypertension and ankle edema in pregnancies that had resolved with delivery. Clinical examination revealed no significant abnormality other than this median nerve entrapment, and she did not have the livedoid rash. Father was completely well, clerical worker with a completely normal clinical examination. Brother 1 at the time was 21 years old and at university. In 2006, he had had an episode of what was thought at the time to be self-limiting Henoch-Schurlein purpura. He also had an episode of testicular torsion. In 2014, he had been admitted whilst a university student to another hospital in the north of England, where he had had an episode of fever with ankle arthritis. And interestingly, at that time, he had no acute phase response at all. Livedo reticularis was noted, and he had diarrhea and weight loss and night sweats. These symptoms spontaneously resolved after a few weeks. And I know that because I spoke to the doctor who was looking after him many years later, and we pulled up his case reports. In fact, I can show you a picture. This was his ankle at the time when he had the significant arthritis, and you can make out that there is a faint livedoid rash around the wrist. So brother 2, at the time I met him, was 17 years old. He was an A-level student. He had no significant illness history, but he also had this episode of self-limiting testicular pain, at the time thought to be a self-limiting testicular torsion. He presented at the time with postprandial pain, with diarrhea and no fever, but intermittent night sweats, and some cold or exercise-induced libido, but had a normal clinical examination. So we did some investigations and we found they had no significant marked acute phase response despite regular testing. They sent us blood tests every 2 weeks in the post, and we were able to track them for a number of months, and there were no elevations. They had borderline low IgM and the other immunoglobulins were normal. Renal function was normal, blood pressure was normal, and there was no active urinary sediment. So if you compare this to the clinical course reported of the same mutation as in compound heterozygote state in the original publications, these patients had significant stroke. They had very marked clinical presentation of what we now call ADA2 and had mixed response to treatment. They also had no significant inflammation, even in the acute phase of their illness. We decided to do some non-invasive imaging on the family to see if we could identify any abnormalities. Visceral MR angiogram revealed in brother 2 perhaps a suggestion of some thickening of the superior mesenteric artery, but we decided not to pursue invasive angiography as he was well at that time. Neuroimaging, including that of the vasculature, was all normal. Very kindly, Gustavo Santo, who's I'm sure in the audience, just performed some ADA2 activity levels for me. We found that compared to healthy controls who did not have mutations, that the wild type father had reduced activities of ADA2 enzyme, and brother 2 and mother, who were the only ones we tested, had low or almost absent levels. I know that Professor Brogan's group had also done activity in brother 1 and found that to be low or absent as well. So the clinical course of this family over 5 years. So in the UK, we have very limited access, as you may recall from the last meeting, to anti-TNF for this indication. And the proband has been stable on anti-TNF for a number of years. And brother 1 has had intermittent symptoms, but we did not treat him. Brother 2, in fact, has had recurrent abdominal symptoms and was due to start anti-TNF imminently when I last spoke to his treating consultant at the Royal Free last week. The sister is asymptomatic and we have never treated her. Father, who is a heterozygote, you may recall, was never treated. And the mother has intermittent rash and migraine, but again, we have not treated her. So what else do we know about asymptomatic cases with mutations? Well, we also know that ADA onset of ADA2 is well recognized. I've borrowed this from Aman Sharma's very nice paper that came out recently showing that ADA onset was actually not unusual in his cohort. And also, if you look at the published data and compare them, you can see that people are still presenting over the age of 20 and certainly some up to the age of 50 in the published literature and beyond. And what do we know about prevalence? Well, all these people who present with ADA onset have been walking around without symptoms thus far, and we know that, they tell us that, they did not have any symptoms prior to presentation. So what is happening within the general population? We know that there are low levels of symptomatic ADA2 in adult vasculitis cohorts, and when you look at the recent publication by Peter Merkel's group, we can see that. So I asked my collaborator, Professor Richard Trembath, who heads up a large genomic databases in the UK, to kindly look through his big, large whole genome sequencing. And he reviewed the East London Genes and Health Project, which has 47,558 whole genome sequence from the Bangladeshi and Pakistani origin, and the Born in Bradford study, a separate study, which was much more of a wider demographic, 25% being South Asian and the rest being Afro-Caribbean and Caucasian British, and that had 13,500 people in them. In total, 3 patients were found, 3 people who'd had their whole genome sequence were found to have heterozygous predicted loss of function variants. All were asymptomatic at time of genetic DNA being submitted to the registry. We found 6 homozygous variants that were not predicted to be deleterious, and all were asymptomatic at registration again. So we assume that prevalence of these mutations is fairly low in those who are healthy and well. And what does that imply? Should we be looking more keenly for somatic mosaicism in those with adult onset? And what about ADA2 activity levels, our functional gold standard assay? Well, I have not been able to find a single case in the literature of biallelic variants with no symptoms and normal ADA2 activity. We are either not doing enough functional assays or we are not reporting enough of the functional assays, particularly in family members who have mutations of uncertain significance or are asymptomatic. I would argue that I think this is essential work that needs to be done. So I refer back to the Delphi consensus study that many of you kindly helped me do. Starting in 2017, we had round 1 where 69 of you responded, and round 2 later on in late 2017, early 2018, with 53 participants. Because I want to show you your results from that time, and I wonder whether they have changed. Because we do have a bit of a dilemma here. Despite some population prevalence, albeit low, and despite recognised adult onset, most of us are not routinely investigating or imaging asymptomatic family members, even though we know they are likely to, or we do actually know that they have silent, presumably silent, ADA2 mutations. So this is, I don't expect to go through each of these results, but I just want to show you that there was generally a large proportion of people who were experienced in looking after ADA2 patients, but actually did not routinely follow up asymptomatic cases or investigate relatives. So I look at this one here and I asked you, I do not follow up asymptomatic carriers, 34% of respondents. I only follow up carriers if symptoms arise, 19.7%. In my current practice, I only request gene sequencing on relatives who have suggestive symptoms, 17%, but then on the converse, we had nearly 70% requesting sequencing on all siblings and parents. Would you perform surveillance imaging on asymptomatic carriers? And the vast majority of you said no. So what do we need to know? Well, I think we need to know if you can have biallelic variants, normal ADA2 activity, and lose that over time. As we age, do we need less ADA2? It's possible. We do already know that children have higher levels. And is there a safe age after which stroke risk is reduced? Is there any evidence of somatic mosaicism that may explain adult onset? And if not, what are the mutations, what environmental or other cofactors may be involved here? I'm sorry to ask so many rhetoric questions, but that is the nature of this talk. And we really need to define disease activity. We cannot have disease activity defined post-stroke. I think that is an absolute disaster. So we have to look for biomarkers and we have to have a consensus on what we believe are suggestive symptoms and work out how sensitive and specific those are. So how can we get there? How can we start to answer some of these questions? Well, I think it's probably obvious to all, but we clearly need a consented observational cohort study or registry. I know that Dr. Chambers is keen to support that through his amazing foundation, and I think I'd be very supportive of that myself. But there are ethical dilemmas with doing this. Logical burden, potentially deleterious variants of unknown significance. There are possible legal and financial consequences, such as life insurance and health insurance. And we would need to all agree on a structured diagnostic workup with a structured follow-up and a very long duration. So I'm coming to the end, and I just wanted to summarize. We know that asymptomatic individuals with biallelic variants have been reported, but are they truly asymptomatic? We recognize true adult onset prior to symptoms, and these were asymptomatic, but is asymptomatic always pre-symptomatic? Can you have mutations and have normal ADA2 activity and lose these over time? Are other mutations and cofactors involved? I think the answer is almost certainly. How are we going to identify these? Realistically, we can start anti-TNF on all cases, or can we afford not to? And I think it is essential that we have a registry with very long-term follow-up. Thank you for your attention.